tPA and its role in treatment for ischemic stroke. Tissue plasminogen activator, often abbreviated tPA for short, is a serine protease found within endothelial cells that activates plasmin, which in turn breaks down blood clots in the body. tPA was first approved by the FDA as a fast-acting treatment of ischemic shock in 1996 and is still today considered the only FDA-approved treatment method for acute ischemic stroke. Ischemic stroke occurs when a thrombus, a fancy term for a blood clot, either travels to or forms in a blood vessel in the brain, partially or fully obstructing the flow of blood through that vessel. With little to no blood flow through the blood vessel, all downstream brain tissue is quickly starved of oxygen. Due to the high metabolic activity of brain tissue, irreversible damage to the poorly oxygenated region of the brain can occur in as little as 3 minutes. If left untreated for any length of time, ischemic stroke can lead to speech and language problems, memory loss, paralysis, and even death. Ischemic strokes are most often a direct result of atherosclerosis, a condition in which plaque and fatty deposits build up on the walls of blood vessels and narrow the diameter of affected vessels. Without treatment, these plaques can continue to grow in size and eventually rupture, often tearing the vessel wall as it breaks. To prevent profuse bleeding from the plaque rupture, the clotting cascade is triggered, where the body attempts to seal the leak in the vessel through the formation of a clot. Most important in clot formation is fibrin, a non-globular protein that polymerizes to hold together the platelets that form the bulk of the clot. Fibrin is formed by the action of the protease thrombin on fibrinogen, a soluble protein present in blood plasma. When a plaque ruptures, the release of tissue factors helps recruit thrombin to the affected area. From there, thrombin binds to fibrinogen, and catalytic cleavage at the N-terminus alongside the glycine-proline-arginine sequence of fibrinogen releases fibrinopeptides from the molecule, thus forming fibrin. This cleavage exposes the glycine-proline-arginine residues and allows for covalent interactions with binding pockets of nearby fibrin molecules, causing fibrin polymerization. The presence of exposed cysteine residues on each fibrin further allows for the formation of disulfide bonds between fibrin chains, helping form the cross-linked fibrin mesh of the clot. While the clotting cascade is undoubtedly important, excess clotting can often have a negative effect. Under certain circumstances, the resulting clot can become dislodged and travel throughout the body. In a healthy individual, this is somewhat less of a concern. The smooth surface of endothelial cells that line our blood vessels help prevent clots from sticking against the walls of our vessels. However, in atherosclerotic patients, the surfaces of these plaque deposits are often much rougher than normal endothelial tissue. This roughness makes it much easier for free-floating clots to latch onto the affected vessels and block blood flow to the region. This is where tPA comes in. tPA is a serine protease that cleaves the arginine-valine peptide bond of plasminogen, an inactive molecule located within the plasma of blood. Cleavage of the bond activates the molecule and forms plasmin. Activated plasmin then attacks the fibrin forming the clot, cleaving peptide bonds between fibrin molecules to help dissolve the clot and return blood flow to the ischemic tissue. If administered fast enough, tPA has the ability to completely prevent adverse side effects as a result of an ischemic stroke, even providing benefit to the patient as far as 3 hours following the onset of symptoms. Outside of these 3 hours, however, administration of tPA may very well do more harm than good. Recent research has suggested that intravenous administration of tPA may play some role in spontaneous hemorrhages in the brain. By activating specific growth factors in the body, tPA may be inadvertently responsible for increasing the effective permeability of the blood-brain barrier, which has been linked to higher propensity for intracerebral hemorrhage in both mice and humans. Even despite this limiting factor, tPA is still considered to be one of the most revolutionary treatments of the 20th century. However, it is still important that research continue for ischemic stroke treatment methods. We have seen that tPA is by no means perfect, and a therapeutic that could potentially locally induce clot dissolution without systemically affecting the human body is likely the next step in treatment to limit contraindications associated with ischemic stroke treatment.